Good afternoon, everyone. We're going to go ahead and get started. Tracy O'Connor and I are going to talk about the care redesign, just a general high-level overview today. So later on in the series, probably at the end of the June, maybe early July timeline, we'll be doing a really in-depth with protocol details and implementation, and that'll be closer to when the groups are starting to look in that area. So, but today we're just going to do a high-level overview, and certainly if you have questions, you can send them in. Okay. Well, we'll skip this page. We won't have really. The agenda for today is the BPCI Advanced CMMI Initiative, Care Redesign Implementation Requirements, Care Redesign Benefits, Process, Quality Measures, Care Design, Redesign at a Glance, Potential Areas for Redesign, and then the Fusion5 core services. So for the groups that have been in, they may already recognize or know this, but this is CMS's definition of the care redesign. It means specific plan of intervention and changes to the current healthcare model, of which elements may include interventions and changes to improve the quality of care, the beneficiary outcomes, and beneficiary experience of care, intended to result in initial internal cost savings and the positive NIFRA. Their goal is, the quality performance measures and targets. And why this is important is because, we enter into this program, and it's really a voluntary program for the BPCI Advance, and the CMS and CMMI is anticipating that there is going to be that, that motivation and that goal to change healthcare, that we're looking at the future, we're looking at transition, and that all those participants are going to be, changing their practice patterns. So it's a quality, the quantity of services offered by providers, and it's shifted to a quality of care environment. So some of you may not know also that when we submit as a convener, when Jerry provides the application, there is a process and interventions that must be listed on the implementation protocols. It includes a physician care plan intervention, hospital interventions related to gain sharing, and post-acute care interventions. The care redesign implementation protocols need to be completed for each episode. For each episode initiator, it's rolled up, and that information is submitted to CMS and in the September timeline, and then that's part of the program. So with that, CMS will do the audits. Really, they're looking to see if it's a scalable program. They're looking to see if the outcomes are quality-based. So some of you may remember that CMS, at times, they will do on-site audits, and what they'll do is they schedule with the group or the practices, and they go and they have questions. It's provided by a third-party provider that collects data based on the program, and it engages with, the patient surveys, the protocols that you have in place, and really they're looking to see if what data that they collect, if the outcome, of the program is quality, and if it's effective. They are very concerned, obviously, about their beneficiaries, and they want to see if the program can be used on a larger scale with outcomes. And so they're really just looking to collect data, and then from those that were in the program before, you may remember that then CMS sometimes will publish outcomes and share information from other programs where they feel that there's quality, and initiate or try to get other practices or conveners to use some of those, strategies for their group. So some of the benefits of the BPCI program, obviously from the physician point of view, the quality of care for their patients. We know that they strive for that, and they like to hear that feedback and see the data that recognizes their quality in care. And then there's a financial incentive from CMS. The program also allows for standardization of care. A lot of the practices, hospitals, just any physician group, we see that there's, fragmentation or differences of practice patterns. So with the program, it really encourages the evidence-based sharing of information, sharing of data, and standardization of care. So that usually takes a process that's not immediate. So the practices that are just engaging in the new program that haven't been part of the classic will see that there's a process that takes place. Accountability of network providers, which we all know is very challenging, and Tracy will talk more about that in a little bit. It also identifies gaps in care and treatment fragmentation, increases patient satisfaction, and then provides a readiness for transition to the value-based care program. So those are just a few examples of what we look for, benefits. So Jerry's talked about this before, and we won't go very in-depth in it. It's just a simple reminder that care redesign also includes quality measures. So I know from the financial side, we talk about that, we need to collect these, we need to have good outcomes for the financial incentive, but this is also very important, obviously, on the clinical side. So we want to make sure that, those readmissions and advanced care plans and different initiatives for the program are captured and the outcomes are good. So, okay, Tracy.
Great. The care redesign process. It's important to follow a process and determine what works best for your organization, because there is no one recipe or one-size-fits-all care model. There have been many changes in medicine, technology, financing, and patient demands that require providers to constantly reinvent. Now, Medicare is linking their payments to successful redesign. The process itself is analyzing or analytics, determining the team, implementing process changes and protocol development, and then continually improving through evaluation and refinement. So analytics is the first step. I found this quote, and I think it's quite appropriate. The goal is to turn data into information and information into insight. The amount of raw data that's delivered by CMS can be very daunting. You need to be able to do an analysis of your past performance and cost and see the opportunities, and then have insights to predict your financial exposure based on the population you're managing. You will have access through the Fusion5 analytic and case management system to online data reports. You'll also be able to look at special reporting on cost drivers such as post-acute care performance and readmission details. The second part of it is platform for care coordination. You need to be able to follow your patients through the continuum of care. You need to be able to perform a risk assessment, determine patient optimization strategies, track and follow conversations and messages with patients, initiate custom care plans and interventions. For example, you need to be able to track weight gain in a heart failure patient and possibly increase a diuretic to prevent readmissions. The Fusion5 system will give you this platform. It's also important to have those specialized analytical tools that can provide view into future trends, and that is looking into your post-acute care performance and your readmission detail. And lastly, tracking and benchmarking the performance of your bundle. You can customize your measures depending on end user requirements, and there are pre-configured key performance measures across a range of incentive programs. The second part is determining the team. Simply stated, teamwork is less me and more we. The most important part is to determine a champion. This person can be a physician, it can be an administrator or a BPCI coordinator. The person will have authority over the project and over the individuals who will implement the change. This person really knows how to engage and involve the right people and brings the vision to life. The second important component is the care manager. I want to stress here, there are many different models in BPCI, and you need to be able to determine which model works the best for you. There are alternative models Most of us in the past have worked with the traditional embedded case manager model, where the group hires a case manager who is in the past an RN or a physical therapist, and they follow the patient through the full 90 days. There are other models available. We'll give more detail about this in latter webinars, but we will have a high-risk model in which high-risk patients can be followed by specific identified resources. There's going to be an existing resources model in which the organization can use its existing team in place and augment their contact to the patient with messaging. Furthermore, there's a full telephonics model. Again, we'll have more detail of those different models, but care management is an integral part. They support the physician or surgeon. They focus on complex or high-risk patients who can really benefit from additional education, care coordination, and management of goals. Typically, they operate at the top of their license, and they proactively identify the high-risk patients. The third member of the team is really the multidisciplinary team, that individuals outside, your physical therapist, your hospital staff. Sometimes you can involve people from your skilled nursing facilities as well. But it does take a team. The next step is process change and protocol development. And I loved this John Lilly quote: "Our only security is our ability to change." Health organizations, new and old, are addressing the shift to value through invention and innovation. The first step really is risk assessment and patient optimization. It's making the patient as healthy as possible before surgery to have a better outcome. Second, it's developing clinical pathways or using evidence-based research to make decisions. The third part of the process is SNF and home health protocol development. Fusion5 has an entire team that is dedicated to helping develop that network and giving you the support you need in that area. There's also been some out-of-the-box thinking to prevent readmissions. We've seen this a lot in specialty clinic development for hospital-based and medical-based episodes. Specifically, we've seen this in sepsis clinics and heart failure clinics where they have a same-day visit to the hospital instead of a readmission. And thirdly, it's care coordination through the entire continuum of care. This includes the risk assessment, education, phone calls, messaging, medication reconciliation, and transitions of care. The process starts 3 weeks before surgery. It can start before that time frame and lasts for a full 90 days after discharge from the hospital. The system is changing to value-based care. Fee-for-service, as we know it, will maybe not exist in 10 to 15 years. So BPCI Advanced is giving you the opportunity to get ahead of the game. It's determined how to apply value-based care to your organization and to get paid while doing it. The last step is to continually evaluate and refine your process. I quoted Henry Ford on this, and he said, "Failure is the only opportunity to begin again and move more intelligently." We've learned through BPCI Classic that it is continually making changes and getting better. You can't make all of the changes up front. You need to be able to identify the performance gaps. You need to be able to refine the process to improve the performance and meet with the multidisciplinary team regularly. It's creating a culture of continuous improvement. I like to think of the Kaizen model of everybody improving everywhere and every day. You can utilize case studies to analyze high-dollar cases, perform readmissions analysis, and have surgeons speak to each other about their success. The Fusion5 team will meet with you regularly to evaluate and continually refine as well. We will orient you to the new BPCI Advanced process. We'll meet with teams, members of your organization to set up the program, and then we'll have weekly and monthly meetings with your team, usually with the care managers, the coordinators, possibly the surgeons, to continually improve and show best practices. There are major overarching ideas in care redesign that we've seen through the first program. The first is really looking at the patient holistically. It's that risk assessment and making sure the patient is optimized before surgery. It's thinking about sending the patient home to heal. Now, that's not applicable in all episodes, but in some cases, patients can go home, and the mobility they'll be getting, moving around their house, going to the bathroom, getting up and preparing their food and getting back down is what they need to heal. It's about risk stratification and putting in place strategies to help the patients that are higher risk, that have comorbids that need to be managed during the 90 days. And it's about care management, facilitating the transitions of care and following the patient for the full 90 days. Giving them the right level of care at the right time. It's about managing those post-acute care providers and setting up preferred partners, working together to prevent readmissions and reducing the unnecessary cost. It's also thinking about a budget, not managing to a cost, but thinking about potentially having somewhat of a budget on your episode. So then you can break down care redesign into 4 different areas. The first is the pre-acute, and this is where the risk assessment takes place. It's also looking at the biopsychosocial concerns, such as chronic and comorbid condition management, social and community support, identification of behavioral health needs, and patient coach identification early on in the process. It's about engaging your physicians, preparing the patient to heal at home, and using a predictive model with adjusted risk stratification across the continuum of care. There are things that can be done inpatient while the patient is in the hospital, such as early mobility programs, making sure the patient can walk the day of surgery. You can have one-on-one meetings with the pharmacist. This is important in your cardiac episodes because we find that a lot of the issues are because of lack of compliance with the medication, lack of understanding of the medication, or potentially the funds to get the medication. There can be specialized discharge instructions by the case manager. There's post-discharge care planning and early identification of patients on an unplanned episode, such as trauma. You need to find a way to identify those patients in the hospital. The management of the post-acute facility is another area for redesign. It's building those preferred partners to reduce the length of stay and readmissions. Development of post-acute care protocols. They can be specific to the episode type. For example, you can have cardiac protocols, which incorporate low sodium diets, certain amounts of exercise. Discharging the patient as appropriate to home, with or without home care, and readmission rate reduction. And lastly is the remaining 90 days of the episode. And it's all about managing, again, the patient for those 90 days, preventing the readmissions. For example, if a patient has a hard, warm calf, you can bring them into the office to do a Doppler to check for potential DVT instead of sending them to the emergency room. It's all about using waivers. We talked about that in one of our earlier webinars. It's using new technology, such as telephonic, being able to communicate with your patients over the phone, using the camera over the phone, messaging systems going back and forth with answers instead of having to physically talk to the patient on the phone. We've talked a little bit about the specialty clinics to manage special situations and really developing your community resources. At Fusion5, our core service number 2 is all about care redesign, and this is something that we will hold your hand with to develop. We have the case management system and patient tracking software. It's a very intelligent system. We will be demoing a little bit more of it tomorrow. We have predictive and risk-defined models in it, evidence-based medicine and assessments. We have a proprietary risk assessment and many other assessments that have been added that you can use to assess your patient. And it also has suggested workflow and care coordination processes.
So some of the things that, you know, based on experience we have had over the last 3 or 4 years, we were able to really look at the gaps of the care redesign and the infrastructure and some of the modeling of the program. So just as a quick overview, a few of the things that we really focused on in the program development for the advanced was providing a system-generated predictive model. So in the predictive model will be intelligent, as Tracy was saying earlier, that over the course of the program, it will not stay the same. It will, you know, it's like a machine learning tool. It will advance and will adjust according to what our outcomes and our patient population is, whether it be orthopedic, cardiac, or a medical condition, you know, such as, you know, CHF or one of the other pneumonia, COPD. So we'll be able to really adjust our clinical pathways accordingly based on evidence base and based on data. So the risk identification and adjustment throughout the episode of care, I think that we identify that there are circumstances where a patient may be low risk and a subsequent event creates them to change risk status, whether it be DVT or CHF. They lose support in the home. There's a defining social matter that occurs, and it changes. It could be a fall, but it changes their level of risk. And so we felt the need for adjustment throughout the episode of care. So allowing, and that would allow to the next one, the staffing model. So we recognize that the patients need to have higher touch points with high-risk patients. Generally, those are lower volume, but create a need for a higher level of acuity and touch points. So we've adapted the care plan and the system to incorporate those types of things. So the optimization is another area. It's very much expanded. So there's been thresholds identified by the practices before, normal preoperative testing, but some that are parameters for the patient being delayed versus going forward. So we've adjusted those even further to allow for additional clinical teaching of the patient and provide the clinician with resources for educational purposes. Adjustable workflow and assessment integration, ability to incorporate multiple service lines. So we're definitely looking, as the program moves forward, to incorporate commercial and other service line areas. Clinician resources that we touched on just a little bit for the chronic and comorbid. So a patient that is an orthopedic patient is not obviously just a total need. A patient is a whole patient. They have comorbids and conditions, and so we recognize that the clinician has to have resources that's available, that when they're talking to the patient and they identify a need, that they can follow that or conclude that conversation by telling the patient and that I will forward you additional information after our ending of our call, and that you can read or use for a resource, or for the clinician's purposes for diagnostic or any type of thing. It's evidence-based. It can help them through clinical guidelines to help them be a clinical decision-making process. So the patient engagement part, we recognize too as part of our experience that the patients really need to be engaged. So engaging the patient throughout the whole episode, whether it's through education or, you know, education, teaching, you know, whatever the case may be, that needed to be communication. So that's something in our program that we're really focusing on this time by allowing the patient to have access to a portal, a team clinical team messaging. They can do their own surveys, and so really engaging them in their recovery process, having them buy into the wellness of their situation or their condition, so that that better outcomes and better patient satisfaction, I believe. So, but as we touched on care team messaging, PAC, provider engagement, this time I think we've recognized from previously how challenging it can be when you have a network provider group and the staffing turnover, how challenging it is to maintain that consistency in protocols and education. So we're providing and we're very dedicated to having a team that will build those relationships with the practices and maintain those relationships and accountability and provide education on an ongoing process to them. So it's not such a burden, I think, on some of the practices. So program discharge, transition of care, patients, they don't end their need for their conditions, whether it's orthopedic or medical conditions, at the end of 90 days. There's a transition of care plan or process in place. So the transition the patient back into the community, back into their primary care, their to another specialist. So so we have that process in place. And then I think we talked about a little bit before the ability to incorporate multiple service lines. So that's just a few of the things. I think that Tracy mentioned tomorrow we'll be providing a preview to our care coordination system. The full system will be available at the conference in June. That's June 27th through 29th. And we will be going in depth with that tomorrow. Will be workflow, gives the care coordinators an opportunity to see some of the available resources on the system. So, and that'll be again followed up in June at the conference with the full a view of everything. So. Next week's webinars will be alignment strategies, how we maximize BPCI together. We'll continue to schedule face-to-face meetings. I know that Jim and Jerry and quite a few others on the team have been reaching out and setting up, meetings for opportunity analysis very shortly. We anticipate by the end of May, which is just today and tomorrow, that we'll get the data from CMS. So it may be a couple days to a week before we can get all those, that mass amount of data into reporting and being set out for target pricing, but that will be, it's just around the corner. So look for those emails and, for our team to be reaching out so that we can schedule on site. So, and then the conference, if you're interested in coming, and you do not recall that you received any information, please reach out to somebody on the team, myself, Tracy, Ryan, Dylan, and we can certainly provide again that information. So again, if you have any questions, be sure to send them to the email that was provided at the beginning of the conference, and this will be recorded, be available sometime next week.
Thank you so much for your time today. We really look forward to working with you.
All right, everybody have a good day. Thank you.